of a course on pediatric disaster life support. And finally, he is the principal investigator on PRIDE, the Pediatric Research and Disaster Education Network, which has been doing some of the same type of work that Scooch and Bob will be talking about today related to disaster triage. And he is currently funded through the Emergency Medicine Services for Children Targeted Issues grant for that work. He lives in Hamden, Connecticut with his wife, their 3 children, and 3 disastrous cats. Bob Pascucci, Scooch, as many people know him, is based out of the Children's Hospital Simulator Program in Boston, and he's been involved in the development of simulation as a teaching tool for pediatric residents in their ICU rotations. And in this capacity, he is focused on the use of simulation to teach not only things like crisis resource management and typical ICU skills, but also team development and many other exciting new facets of simulation. He's a member of the Program to Enhance Relationship and Communication Skills, PERCS, and he's been instrumental in the expansion of simulation teaching techniques to the domains of interpersonal communications through that program. PERCS participants explore and expand their ability to communicate and develop a relationship with parents, patients, and other healthcare providers as they deal with difficult conversations, such as end-of-life issues, medical errors, or angry parents in the course of providing their healthcare. In addition to providing all of that simulation work, the program is attempting to develop methods to assess its effectiveness and videotapes and uses some evaluation tools. Scooch has also had some theater and drama experience as a director and really added some great perspectives to our work, to Bob and to Scooch and Mark's work at the IPSSW meeting. So with that, long-winded introduction, I'll pass things on to Bob and Scooch, and they'll go till about 12:30. And again, if you have any comments, just put them in the box there.
Hello, everybody. Thanks for joining us. This is Mark Cicero, and on behalf of the rest of the gang whose names you see on the screen, including Scooch, he'll be adding color commentary and speaking about some of the orchestration and the obstacles that
always adding color.
Indeed. Our multimodal sim. I'd like to welcome you all to a discussion that at first may seem like a very particular discussion, particular to how we staged a multimodal simulation as the opening simulation in this spring's IPSSW meeting. But really, there are themes here as far as how if you are an educator who uses simulation, you can use multimodal sim to accomplish your goals and objectives. If you're a researcher, you may be able to do that. And if you're someone who's interested in disaster medicine, as I am, you can use multimodal simulation as a way to test new ways to manage many patients, perhaps simultaneously or in rapid succession. So with that in mind, we can move on and just take a look at our own goals and objectives. For the educational sticklers in the group, there may be perhaps 3 objectives per se and 1 goal here. We'll take a look at the different modes of simulation that can be used concurrently. We'll take a look at some clinical situations that can be simulated with multiple modes and patients. When we get to that section, I'd be very curious during the discussion phase of the webinar if you all as participants have other ideas about ways that we can use multiple modes of simulation to simulate particular clinical situations beyond the examples that we thought of when we put together the webinar slides. We'll take a look at some of the obstacles and the benefits of multiple patient simulation, and also look at our team's experience, again, in conducting that multiple modal multi-patient simulation in New York City this spring. So first, to look at the different modes of simulation, I'm speaking with you from the Eastern time zone of North America, South America, in Connecticut. And right now it's lunchtime. And this uncooked potato may not look too appealing for those who may be hungry without being prepared. But for someone who is an educator or someone who's looking to learn a procedure, this lowly potato may be a way to learn. a way to simulate a procedure that may need to be done. Think about doing a biopsy of one of these little marks on the skin of a potato, or perhaps learning the proper way to inject an immunization. This is a low fidelity example, and when we talk about low fidelity simulation, we're talking about a methodology or a modality that does not mimic the physiology of the patient or the condition that we're trying to simulate very well, but can be used to learn a task, or can be emblematic or symbolic of a patient in a situation. So here's an example of a low fidelity simulator, a potato in this case. It visually represents the patient. It can be used for teaching tasks, injection, or perhaps lumbar puncture. Another example of a low fidelity doll is shown here. This looks a lot more like a person than a potato, and certainly has its applications if we're looking to simulate multiple patients simultaneously. These tend to be less expensive than other ways to simulate a patient, and a potential obstacle to using them is learners automatically see the potato or perhaps the toy doll as not real, and recruiting their buy-in can be more difficult with low fidelity simulators. It's a feasible means of portraying multiple patients if, for example, we're looking to simulate a collapse of a bleacher at a sporting event. Then if we have multiple patients in the wreckage of the simulated bleachers, several dolls can easily portray the patients and be acquired for not too much in the way of cost. And then also, low fidelity simulators can be augmented with audio and visual aids. The next slide may be a bit disturbing, but it takes a low fidelity doll and makes that low fidelity doll portray a gunshot victim. With some moulage, some makeup, a little imagination, a low fidelity mode of simulating a patient can have some dramatic results and be an effective way to conduct simulation. If we move on to medium fidelity simulation, here's an example of a medium fidelity mode of simulating a patient. This has some representation of patient physiology. This particular mannequin has breath sounds, but doesn't have chest rise. These type of simulators are moderately expensive and have moderate fidelity. And we can, again, augment this kind of simulator with audio and visual aids. In fact, for a little foreshadowing, our simulation that we did at IPSSW was an apartment fire in New York City. And this particular mannequin that's before you now, you can see that there's some smoke that's accumulated on his pajamas and also some soot around his nose and mouth. If we move on to the high fidelity ways of simulating patients, here's one mode. This is one of the stars of our simulation at IPSSW. We can see that this is a mannequin that has hookups that attaches him to a computer. This mannequin can breathe. This mannequin can have vital signs that can be controlled and can respond to interventions that learners make in his management, and can portray a variety of different clinical situations. Again, this represents a modality that approaches human physiology closely, or relatively closely, when compared to, say, potatoes or baby dolls. This type of simulator has a wide array of vocalizations and verbalizations and can be programmed, again, to respond to interventions. These are costly simulators, and it seems, at least in my experience, that the more costly the simulator, the more likely it is to have breakdown or to have something go wrong when we least expect it. So they're somewhat fragile, but they are an effective way to teach teams to intervene in the care of a patient, and also to get buy-in from learners and to portray the physiologic response to a team or individual's care of a patient. So this is one way to do high fidelity simulation. A person might argue that the highest fidelity simulation is a human being. It's true that the various manufacturers who support our educational and research endeavors have done some phenomenal things as far as simulating patients with mannequins, with synthetic mannequins. But a human is certainly the best surrogate for a human for many applications now. A person can interact with the learners. No mannequin that I've met can portray the emotions around clinical care, around high-stakes healthcare situations, or around disasters like an actor can. So high-fidelity human patient actors and standardized patients. And I'll just pause right here and give a couple definitions. Patient actors come in a wide variety of ages, sizes, ranges of experience, and also the amount of buy-in that they might have to a clinical scenario. For example, in our work that we've conducted for emergency medical services for children and studying how paramedics care for children in disasters, we've had so many actors come through. Some of them are students who are off for the summer, and some of them are really invested in seeing the care of children improved. Others not so much. They see it as an alternative for another type of summer job. Some patient actors are actors in the classic sense. They're actors who might be doing summer stock or be professional actors and have an interest in picking up one-shot work, working with us as simulated patients. And then the standardized patients, when we talk about standardized patients in healthcare, these are people who are educators who use themselves as a means to teach clinical interaction, clinical exams, and really take their work seriously and recognize the importance that they have in both training healthcare learners, nurses, ancillary medical personnel and professionals, physicians, nurse practitioners, and the like. And we've had the opportunity and the pleasure to work with all different kinds of high fidelity simulating actors. So actors are the most interactive way that we can simulate patients, and of course have the most realistic anatomy and physiology. Some of the drawbacks, of course, are people can be harmed. If a mannequin, a high fidelity mannequin is fragile, certainly we as humans have our own fragilities and also can be harmed. An hourly rate for a standardized patient can vary widely depending on where in the world we are and also depending on the skills, knowledge, and experience that that actor brings to the table. So this can be an expensive means of simulating patients. And also, I can program a high or mid-fidelity mannequin to do the same thing every time with every learner who comes through. It can be more difficult to get an actor to act in the same way multiple times a day, week in and week out, year in and year out throughout a project where I'm trying to conduct education, but also to study the impact of the educational intervention and maybe have some other goals in looking at disaster response. So again, humans, the highest fidelity. So here's an example of how we can combine two different high fidelity simulation modalities to have a team work together in an obstetrical case to A, interact with a woman who's in labor and giving birth and the baby's father, as well as actually simulate the birth. You can see that this actor is in a bed and that there is the lower portion of a torso and the birth canal and the thighs that are simulated with a baby who's being taken out by an obstetrical team. So this is one example of a combined high fidelity situation. And this is also the first mixed modal example that we've given in this webinar. Let's look at some others. In addition to multiple patient simulation for obstetrical training, Conjoined Twins might be another example where we can have multiple simulated patients who are together, and this particular example can be used in surgical training. If it is a partial task trainer that might have some organ issues that need to be separated, further enhancing the fidelity of the simulation. And of course, the example that is most germane to our discussion today, some of our research interests, and also the simulation we conducted in New York City, mass casualty incidents and disasters. So I'll give just a little bit of information we can discuss about mass casualty incidents. You know, a mass casualty incident might be any event that has two or more patients that could potentially overwhelm the resources that are available. And disasters can be thought of as larger scale mass casualty incidents or multiple casualty incidents. These events really vary in their scale, how many patients are involved, the duration over which they occur. Say, for example, to give an example of the tragedy that happened at the Boston Marathon this spring, that was an event that had a relatively large scale, that had sort of a punctuated duration. It occurred on one day, and certainly there are people who are still recovering and will continue to recover for a while, but it's an event that happened on one day. The duration of other events, like say a hurricane that has mass humanitarian implications, the same being true for an earthquake, can be ongoing. And also, what are the pre-existing resources? Looking at the attendee list here for our webinar, we represent a group that is largely from the developed world and that is fortunate to be practicing or educating in a place that has abundant resources. If we think about the rural Midwest, if we think about a developing nation in the Caribbean, there are fewer existing resources. Close your eyes and think about a teeter-totter or seesaw on a playground, and think about one end of that seesaw having all those patients and all that clinical need, and on the other end, think about what the resources are that are available: the ambulances, the physicians, the nurses, the hospitals, the recovery staff, the mental health workers, the chaplains. Whatever the MCI is, the multiple casualty incident, children tend to be disproportionately harmed. They're vulnerable in so many ways. So in triaging patients who are victims of a disaster, in sorting those patients and saying, who is the patient, who are the patients who need those resources first? Who can wait? Who doesn't really need much care? And who is beyond help? The guiding principle is to do the most good for the most patients. And it's really utilitarian, meaning, we make some cold decisions in disaster care that might not be made in other situations. Patients who are pulseless and apneic are left without much care at all so that others can be helped. When we think about triage first in disaster situations, it really introduces the scope of pediatric disaster medicine, the overwhelmed resources, the need to consider the whole population of patients and the available resources. And if we think about mass casualty incidents, triage really impacts patient outcomes. If a patient is tagged as red, which means immediate, they are a patient who's going to be transported to a hospital first and receive care first. If they're given any other color tag, yellow, green, or black, then they'll wait and they may not receive care for quite some time. Also, to be honest, few providers, healthcare providers, pre-hospital care providers, have experience caring for multiple patients simultaneously. And really, in reality, there's little time for training when there are so many other aspects of day-to-day care that need to be learned. So there are many ways to sort child disaster victims and many ways to simulate the use of these different systems. I'll only name these. Jumpstart, you can see there. SMART, which is a British system. SALT, which is a system that was developed by the CDC and takes aspects of some of the other systems and was developed by expert consensus. All these three use various color-coded methodologies to sort patients and make decisions about who should be transported first. Sacco Triage was developed using the Pennsylvania State Trauma Database, and it is a numeric score that has the strength of being perhaps the most evidence-based of the systems. However, it's been criticized that it may be impractical to have as many as 12 different designations in making decisions about which patients need to be treated first, rather than red, yellow, black, or the like. And then others have said, listen, these are events that happen so infrequently and that the stakes are so high that rather than using an algorithm that's used only a few times in a person's career, perhaps it makes most sense to sort disaster victims based on a provider's judgment and their previous experience and make decisions that way. And there actually may be some merit to that. So now that we've thought about all those different ways that we can simulate patients and thought about how we can mix those modalities to simulate perhaps obstetrical care and certainly disaster care, let's take our conversation to New York City. This is the New York Academy of Medicine, and New York City is perhaps the most abundantly resourced area for healthcare in the world. That argument perhaps could be made. So many hospitals, so many ambulance systems, and it really has world-class EMS, high-density hospitals, and New York has had the misfortune of being tested by numerous disasters. Thinking about the hurricanes of last year, the flooding, the events of 9/11, and so many other large-scale events that have happened in New York City. So we were in New York City and simulating a disaster. This algorithm is here to be looked at as a whole and not to be studied by all of us as participants in this webinar. Basically, it's here to show that there is an algorithm for making decisions about which patients will be cared for first and who can wait. And I'll draw your attention to the various colors that you see here. Don't even worry about the text. Just look at the fact that there are a lot of ways in this algorithm that a patient can be read. Look at those 5 different red octagons. You can also see that there are 2 ways a patient can be tagged as orange, 1 way a person can be yellow, 1 way a person can be tagged as green, and 2 ways that a patient can be tagged as black or deceased. This algorithm is a variation of START, drawing your attention to the top of the algorithm, simple triage and rapid treatment, and it is a New York City specific variation of the triage system. It's important to mention this because this is the system that was simulated during our simulation at IPSSW. Here's an example of one of our victims at IPSSW, and we used the multimodal simulation to conduct a disaster. We used all the methodologies that were discussed earlier on in the webinar, with the exception of vegetables. Actors were referred to and addressed the mannequins and dolls, and the fact that actors were talking to the mannequins and addressing them by name is a way to get learner and participant buy-in, and also perhaps subconsciously to make participants care more about the inanimate patient representation in the simulation. This mannequin that you see here with a Y and then a hematoma on his forehead had sound loops and other media that added to him, that added to his, hopefully added to his ability as a patient. And when we think about using all these modalities together, what we see here is a picture from some of the simulation we conduct in EMS. We can see that in the foreground, there is a patient who's wheelchair confined, who's being triaged by the gentleman on the right-hand side. And in the background, there's a mannequin who's on a table. And further in the background, there's another patient actor. So there's hopefully a seamless blending of different modalities here to simulate an ongoing multiple casualty event. If you choose to use multiple modal simulation to simulate multiple patients, and you intend perhaps to do the simulation multiple times for learners, and you're maybe perhaps thinking about using that to gather some data and to either test some hypotheses or do some research, it's so important that that multiple patient simulation is conducted in a uniform way. And I'd encourage you, if you're developing such a simulation, to have a bird's eye view of the simulation that can be used as a roadmap, whether it's you and your team at one site doing the simulation multiple times, and especially if that simulation is being done at multiple sites by various teams in multi-centered research. Just a word about the research that we're conducting, looking at various triage systems, like the triage systems we briefly looked at. We're using multiple modal simulation to conduct disaster research for paramedics and EMTs and looking at how they care for patients in disasters. Here are the sites where we're conducting the simulations, including Yale, which is in the U.S. state of Connecticut, Brown in the U.S. state of Rhode Island, and Jumpstart Triage is being tested at the University of Massachusetts, again, in the state of Massachusetts. And the subjects for us, again, are paramedics and EMTs. I won't say too much more about them other than that they represent a wide variety of years of learning and prior disaster training and experience. And the 3 simulations that we conduct include the house fire simulation, a variation of which we conducted at IPSSW, a school shooting, which was all too relevant for recent events here, or events of the last year in Connecticut, and a school bus crash. Standardized patients and simulation mannequins portray the victims, as previously described, the different modes that we use. And suffice it to say that the various simulated patients were conducted via expert consensus, via the modified Delphi technique. And just like we have that bird's eye view that helps us conduct the simulations in a uniform way, we can also look back at the origins of each of our simulated patients and show how and why they were developed. And just like when you conduct simulations, when you're doing education for your patients, there's a need for rigor and for specific goals and objectives around each patient. We carry that forward when we do multiple patient multimodal simulation and still make ourselves have specific goals and objectives for each patient. Let's take our minds back to New York City and back to the spring at the IPSSW meeting. Here were the goals for the simulation that we conducted as the opening simulation of the meeting. We wanted for our paramedics, who we recruited from one of the hospitals in New York City, to accurately triage the patients using New York City's triage system. We also wanted to look at the rationale behind the triage decisions that were made and to share those with the audience, some of whom may have had some previous disaster experience, but many of whom probably didn't. And we wanted to correctly manage the airway and assess the pulses of the disaster victims. We wanted, just like anytime resources are tested by disasters, there's a need for efficiency and accuracy. We wanted these patients to be triaged rapidly. And also we wanted to simulate the interface between the pre-hospital environment and the receiving facilities in the hospitals. This sort of interprofessional communication and collaboration can be taught and people can learn it through simulation and can also be modeled through simulation. And then finally, we want to demonstrate the initial emergency department management of 3 of the victims and also show how even when resources are overwhelmed, there can be some of the initial psychological first aid that's provided to family members. So I'm going to pause for a bit. Goodness knows I've been chatting for quite a bit here, and I'm going to turn the thoughts over to Scooch, and I would suggest that what we have here was perhaps the biggest obstacle to conducting the multimodal simulation. Scooch, if you'd be so kind, just to talk about some of the obstacles that we encountered in conducting this multiple modal simulation.
Well, as you guys can imagine, I'm sure this started as a large project with a large number of patients, and we were trying to figure out how we were going to keep the intent of the simulation, but manage to get it onto that tiny little stage. And of course, the short answer is we decided not to try to get it all onto the tiny little stage, but to do a good portion of it by video, which we actually recorded in the building the day before the presentation. And then to have a setting for everyone that would include the video, would include a little discussion on our part, would include the active care for the 3 patients that we were able to bring onto the stage, and then try to make that all into one mode. Mark, let me see if I can move the slide advance. If I can't, oh, there, look at that. Okay. So to a couple of the specific things that we ran into, one is we were working in New York City and we were going to have to get equipment, and neither Mark nor I are primarily based there. Thankfully, we had the help of a large number of people in New York who were able to recruit people from the fire department and actors and that sort of things for the live part of the presentation, and also to get all the mannequins and equipment together, which was sort of a sort of assortment of stuff from Boston and Yale and various places. Just to comment on the actors, as Mark said, we did use professional actors in this presentation. We arranged to meet them a little bit in advance so that we could talk about the intent of what we were trying to do, and then to have a fair amount of rehearsal time with them before we actually either started a tape or went live. We did find that we needed to rehearse quite a bit the day before. The actual presentation was on a Tuesday, and we were there pretty much all day on Monday, initially setting things up, trying to find out what worked, what didn't work, setting up the room, and Mark had shown you sort of the bird's eye view of the simulation a few slides ago. We actually set that up in one of the conference rooms in the New York Academy of Medicine, and had actors positioned, mannequins positioned, everything working, and then rehearsed it several times and then actually did the videotaping. I found in general when I'm doing video with stuff like this, it's probably easiest just to start videotaping right at the beginning, even though it's a rehearsal type setting. And over the course of, I think we did it 4 times, we were able to get good little bits that we were able to put together into a whole video. The video recording in and on the streets of New York, it's interesting. Obviously, you can't set up a tripod and do videotaping in a public location in a large city without having a permit to do that. And I think that if we'd set up tripods outside and cameras outside, we would have been visited by the New York City Police Department very quickly asking for those permits. So we discussed this in the preparation phase and decided we weren't going to tape outside at all. We did manage to do some actual videotaping inside ambulances. We had the cooperation of the New York City Fire Department and their ambulances. They were participating in the actual recording of the video, and they were there with their ambulances and were able to take us and the actors and a mannequin sort of live into an ambulance, and then do videotaping as we drove around the block a couple of times. And that actually sort of substituted for the transport part of the video. Debriefing for an audience of 300. The biggest thing I would say here is you do have to be careful about your audio, because there's nothing that puts an audience to sleep quicker than a presentation that they can't hear. And they see people talking and they want to know what's going on, and that's often an issue. And the best way to address that is probably with wireless microphones. And I would just make this comment that it's nice to have enough wireless microphones to cover everybody that's on the stage. When we were actually doing the videotaping, we were putting wireless microphones on our actors, and that actually turned out to be, I think, a godsend. We weren't able to mic everybody in the actual presentation on the stage, and if you have the opportunity to set this up, it's nice to look at that ahead of time and try to be able to do that. Audio and visual obstacles, I've already mentioned the biggest one, which is being able to hear. The visual stuff is usually not so bad because people can usually see pretty well. It's being able to hear what's going on and understand what's going on. Mark, I know you've got a bunch of questions that are sitting there. I don't know if you want to go back to you and we can start to take the questions together, or how do you want to do that?
That sounds perfect to me. Really, the conclusion slide, and really, there's just a few other thoughts, which is this is a terrific means for simulating disasters, and really, you can look at the strengths of each modality to augment the limitations of the others. For example, having the actors refer to and be emotionally connected with the mannequins, and have the mannequins do the heavy lifting as far as any invasive things that might happen to any of the patients. And finally, this hopefully results in a believable means for training individuals and testing disaster response strategies. So absolutely, let's launch into some of the questions. And thank you, Scooch, for your thoughts.